Cathy Craven as our speaker today, and Suban. And I'll do a short bio on each of them. So Cathy Craven is a Toronto Rehabilitation Institute, University of Toronto Chair in Spinal Cord Injury Rehab. She's a professor in the Department of Medicine at the University of Toronto and medical director of the Spinal Cord Rehab Program and senior scientist at KITE Research Institute within the UHN network. Dr. Craven is a fellow of the Canadian Academy of Health Sciences and the American Spinal Injury Association, and she has clinical and research expertise in health services and medical rehab after spinal cord injury. She's also the chair of the Canadian SCI Rehabilitation Association and quality lead for the Ontario SCI Implementation Evaluation Quality Care Consortium and the co-primary investigator for the CAN-SKIP guidelines. She's published over 200 articles on related topics and obtained not a small sum of money, 22 million in Canadian research funding as a primary investigator in spinal cord injury. And Cathy's a great friend to the Mobility Clinic and our network, so it's a great honor to have her involved. And I also want to introduce Suban Kangatharan, who's a colleague of hers and a researcher. He's a registered kinesiologist by background and joined the Craven Lab in October 2021. His desire to contribute to the research team in a patient-facing environment has led him to join the Central Recruitment Department as a patient research liaison, as the face of research covering the acquired brain injury, stroke, musculoskeletal, and specialized dementia units at the Toronto Rehab Centre. He's responsible for liaising with researchers and patients to ensure both have equal and fair access, and this involves screening, introducing, and enrolling patients in studies. He's involved in data collection, and the Cardiometabolic project, questionnaire management, providing feedback and educational resources to people living with spinal cord injury disease regarding their cardiometabolic health. So perfectly poised for this presentation. So welcome, Suban, as well. And I'll now turn it over to Cathy and Suban.
Thanks, Jamie. I appreciate the warm welcome. And thanks, Joe. I'm thrilled to have Suban and I present today. We're going to share with you some work on cardiometabolic disease after spinal cord injury that came following development of the SCI high indicators, which was a Praxis-funded project. And I noticed that Vanessa Noonan is in the audience and Matthias Weist, who helped to author the original SCI high cardiometabolic indicators manuscript. And we're also going to share some recent work funded by the Ministry of Health, looking at implementing cardiometabolic indicators in the community for our SCI patients, which is some work that Suban has led with Reza Miri, as well as our colleagues and friends from SCI Ontario, Sheila Casemore and Navi. So for this afternoon, we had the following objectives: to highlight cardiometabolic disease risk after spinal cord injury or disease, and to really help you, particularly for primary care providers, to recognize this as an invisible disability that you really need to look for, and to really hope that you'll come away from today understanding what is unique about cardiometabolic disease risk in the SCI population versus the general population. I also wanted to talk about some unique comorbid conditions that can complicate CMD risk assessment and management for our patients. And we're going to talk in a lot of detail about key intervention targets, which is trying to address dyslipidemia and inactivity after spinal cord injury. And Suban will share data from a recent QI project, which really highlights the needs for all of us to up our game, including primary care providers, in terms of how we can modify cardiometabolic risk for our patients with some very simple interventions. Next slide, please. So why are we talking about cardiometabolic disease risk? And this is the thing we really wanted to bring home. Heart disease is really the leading cause of morbidity and mortality after spinal cord injury. The prevalence of symptomatic heart disease in SCI is about 30 to 50% in older cohorts with motor complete spinal cord injury. But the prevalence of asymptomatic heart disease is 60 to 70%. And recent work has shown that we are seeing a rising incidence of those with motor complete paraplegia who develop early hypertension after spinal cord injury. So we do not want people's first diagnosis of heart disease to be when they have a heart attack or a stroke. We really have opportunity to improve our primary and secondary prevention for patients with spinal cord injury. That's why we're here today. Next slide, please. So what is cardiometabolic disease risk? And as Matt has written, it's a clustering of interrelated risk factors that promote the development of atherosclerotic vascular disease and type 2 diabetes. And these disease processes ultimately combine to cause narrowing or blockages in blood vessels that result in heart attacks, angina, or stroke. And as we said, is one of the leading causes of death. Next slide. So when we look at cardiometabolic disease, there's recently been a really great publication from the Paralyzed Veterans of America. If you go on to the Consortium for Spinal Cord Medicine website, you can download these guidelines that looks at a number of risk factors that define the presence of cardiometabolic risk. We're looking for the presence of any 3 of the criteria shown on the screen. So a person with a body mass index greater than 22 kilograms per meter squared, or 22% body fat for men and 35% body fat for women on a whole body DEXA. For those of you who have access to whole body DEXA that can look at body composition, this number can be found very easily. But for those of you who don't, you can look at your weight and your height and calculate your body mass index. We're looking at those who have a plasma triglyceride level greater than or equal to 1.7 millimoles per liter, or a reduced HDL or good cholesterol, less than 1.03 for men and less than 1.29 for women, an elevated blood pressure of greater than 130/85, or the requirement for use of medication for hypertension. And we'll talk about that in a little bit more detail. And then the presence of an elevated fasting glucose to be diagnosed for either pre-diabetes or diabetes, with the values between 5.6 and 7 being pre-diabetes, and type 2 diabetes being a value greater than 7. So for those patients who have greater than 3, they would be defined as having a cardiometabolic risk and having an increased risk of heart attack or stroke that requires therapeutic intervention. Next slide, please. I did want to talk about some of the specifics of some of the thresholds here, and some of the sort of therapeutic considerations of some of the concurrent conditions that can complicate your assessment. So we know that HDL levels can be an independent risk factor for coronary artery disease. And in spinal cord injury, we often see abnormalities in the ratio of HDL to total cholesterol. We know that the sympathetic nervous system has innervation to the liver and the abdominal tissues in individuals with spinal cord injury that influence circulating triglyceride levels. And we're going to talk a little bit more about neurogenic obesity in a slide or two. We know that there are slightly different thresholds for those who have a neurologic level of injury above T4 versus those who have a lesion T5 and below. And those values are shown in the last bullet. So if you have a neurologic level of injury above T4, we're using a threshold of 115 milligrams per deciliter. And if it's below T5, 137. The rationale for this difference is based on whether the person, we assume that those with lesions T4 and above will have autonomic dysfunction or some degree of it. Next slide. When we think about cardiometabolic disease risk, there's several things that happen after spinal cord injury that contribute to this. And many of you know that I spent much of my career describing changes in bone and muscle after spinal cord injury. So early after spinal cord injury, you have a dramatic reduction in muscle mass, bone density, and you have deposition of fat in muscle and in and around the organs in your abdomen. And this process is called neurogenic obesity. And the presence of fat in muscle and fat in your abdomen creates an inflammatory state that puts you at greater risk for cardiometabolic disease risk. When the cardiometabolic disease guidelines were being developed, there was a very long debate about whether elevated CRP is an independent risk factor for cardiometabolic disease. In my book, it is, and you'll see many patients who come to my clinic that I do offer them treatment for inflammatory stress with coenzyme Q10. And then we also have this mismatch between energy consumption and expenditure, because people tend to be a little bit less active after their spinal cord injury than prior. And the energy cost of activities changes. For those with motor incomplete injuries who return to walking, the energy cost of walking is actually higher. For those who have motor complete and are wheelchair dependent, their energy consumption is a little bit lower. So people need to really sort of look at their caloric intake versus their energy expenditure. And typically most people are taking in more calories than they are expending energy. And then in addition to the spinal cord impairment, when people have episodic physical illnesses, they will have brief periods of immobility or being unwell where they experience physical deconditioning and have to commit to getting back to their sort of pre-morbid state. So I don't know if there's anybody in the audience with a spinal cord injury, but I'm sure they will be able to tell you all about, if you've had a pneumonia or a pressure sore and you've been in bed for several weeks, it is a journey back to get to your pre-morbid physical condition. Next slide. This is a slide which kind of summarizes the concept of neurogenic obesity. But basically what it's talking about is the accumulation of adipose tissue inside skeletal muscle, which increases insulin resistance and the propensity to develop diabetes. And the presence of inflammatory stress, so elevated circulating levels, particularly of TNF alpha, IL-6, and C-reactive protein are the most common ones that we see, that then triggers an increase in lipolysis and contributes to dyslipidemia and the early development of high blood pressure after spinal cord injury. There are several really great reviews of neurogenic obesity. This diagram comes from a article from David Gator and Dr. Farkas. But David Gator has written several really great reviews on this. So if you're interested, I would encourage you to take some time to read one of those review articles if you're a clinician. For patients, I think as long as you understand that it's the deposition of fat where you don't want it, that increases your risk. And I know many patients are familiar with having a quad gut and wondering why, when I'm doing all this exercise, why do I still have a quad gut? And that's because your body is preferentially depositing fat, both in muscle below the level of the injury and in and around the organs in your abdomen. And that causes a cascade or increase in inflammatory cytokines that accelerates plaque formation and the development of atherosclerosis and hypertension. These three things combined together increase the risk of type 2 diabetes, dyslipidemia, and early heart disease in people with spinal cord injury. Next slide. I also wanted to talk a little bit about menopause. And menopause for women, most women will go through menopause around the age of 52. And having menopausal symptoms and trying to distinguish them from autonomic dysreflexia, an acute medical event, or even undetected cardiometabolic disease can be very challenging for patients. And I'm sure many family doctors have heard patients talk about the problems they've had with sleep disturbance and night sweats. And you can imagine for women with spinal cord injury, this is extra complicated because they're trying to figure out, am I autonomic? Do I have a brewing UTI? Do I just have menopause, or do I have undetected heart disease? And I think when patients come in reporting new onset night sweats, we also have to think about syrinx as a medical complication. So increased night sweats really requires very detailed evaluation by either a physiatrist or a family doctor to try to sort out, is the patient actually just simply menopausal? We need to support them through that. Do they have underlying medical conditions, or is this maybe the first presentation of asymptomatic angina? So really important and very complicated. to tease out in women with spinal cord injury, particularly those with lesions above T4. Next slide, please. The other thing that happens to women who know they are in menopause, they have to think about, associated with menopause, women see many, many changes. Big ones that we need to think about is the night sweats, which can contribute to skin breakdown from moisture, weight gain and slowed metabolism. It's very important that as women are perimenopausal and progress to menopause, that we keep track of their weight and make sure that it's stable. And also women will report they need to do more activity because their metabolism has slowed to burn the same amount of calories that they would have in the past. We also have problems with thinning hair and dry skin, and that dry, cracked skin can contribute to an increased propensity for pressure sores. So just things to think about in menopausal women, and women in general tend to be underdiagnosed with heart disease, but this is further complicated in women with spinal cord injury. Next slide. Cardiac arrhythmias. So patients with spinal cord injury can get cardiac arrhythmias. We usually see them early after spinal cord injury in the subacute phases. So when people come from acute care, when they're ICU or in their ICU as they transition to inpatient rehab. As the rehab lengths of stay have shortened, we can expect to see a few more cardiac arrhythmias in the community. The most common arrhythmia that we see is sinus bradycardia, associated with some autonomic dysfunction, but we also can see AV block, supraventricular tachycardia, ventricular tachycardia, and primary cardiac arrest. The primary cardiac arrest, fortunately, is very low, but you will, if you do 24 or 48-hour halters, pick up, patients having small runs of these arrhythmias. So unlike in the general population, where usually most palpitations are atrial fibrillation, early in the subacute phases of spinal cord injury, have to think about some other arrhythmias, including repolarization changes, which can be very simple and require monitoring, to more serious conditions. So sometimes doing those longer Holter monitors can be very helpful to try to help the patient distinguish what arrhythmia is associated with symptoms of palpitations. So it's not something you would do routinely, but only in those patients who are reporting palpitations. Next slide. And then, of course, I think many people are familiar with autonomic dysreflexia. It's a condition associated with a 20 to 30 millimeter of mercury rise in systolic blood pressure, often associated with a pounding headache, heavy sweating, a stuffy nose, anxiety or jitters, and being flushed above the level of your injury. And this typically happens to people who have a neurologic level of T4 or T6 and above. There are odd cases of autonomic dysreflexia reported in people T10 and above, but it's typically those I'll say T5 and above, but T4 to T6 and above. And there are brand new guidelines around autonomic dysreflexia management. And so one thing that can be a bit confusing for family doctors, if a patient comes in your office and that day they were in a rush to get to their appointment, they come to their appointment with a full bladder and they've got some mild autonomic dysreflexia, their blood pressure may be falsely elevated due to their AD, but it's not a condition that requires antihypertensive therapy. It's a condition that requires management of their AD. So if we go to the next slide, please, Suban. For those of you who don't know the lay things that you can do in your office or in a clinic or in your home. So we want the person to sit upright with their head up at 90 degrees until their blood pressure is back to normal, at which time they can lie back down or assume another posture. We want to take off or loosen any tight clothing, abdominal binders, pressure stockings. We want to make sure that there's no kinks or blocks in any tubes that people have. So for instance, if they have a leg bag, that there's no kink or block in their leg bag tubing or in a urinary catheter. During this time, we want to check their blood pressure every 3 minutes and ask about common causes of AD. Is there any possibility that their bladder is overdistended, when was their last bowel movement, are there any new skin wounds that we should be aware of or could try to address. And I think for the lay person, if you have the persisting elevation in systolic blood pressure and you've worked through emptying your bladder, checking your bowel and skin, and you still have this elevated systolic blood pressure, that's the time to seek urgent care and assistance. If you call 911, if you're a patient or a family doctor, they can administer fast-acting nitrates very quickly and lower the person's blood pressure. What is the concern with autonomic dysreflexia? If it goes unchecked with these very dramatic increases in systolic blood pressure, it can cause the person to have a heart attack or stroke. And we do see transient increases in cardiac enzymes for those patients who have quite severe episodes of AD. So if we're not able to manage it quickly in the office, I don't know how many people would have a nitro patch or nitro spray in their office, but if you're not, the 911 team would certainly, if you get a paramedics, they would be able to assist you in lowering the patient's blood pressure. I know a lot of patients hesitate, but really any paramedic can lower your blood pressure remotely and remove the sort of serious near-term issues. And autonomic dysreflexia goes from being an annoyance to an urgency requiring medical attention when you have that gross rise in systolic blood pressure associated with a headache or chest pain. So if you're a family doctor, or clinician, or family member, you can manage an episode of AD by systematically going through this, as long as the person just has the high blood pressure and some of the symptoms. But if they start to develop headache or chest pain, that's the time in which we need to reach out and get more urgent assistance. Next slide. And then the last issue that we see very early after spinal cord injury, and some people who have SIADH, is orthostatic hypotension. And there are a number of non-pharmacologic and drug strategies for addressing orthostatic hypotension. That can be increasing a patient's fluid and salt intake. Providing a patient with an abdominal binder and pressure stockings will raise their systolic blood pressure by 10 to 15 millimeters of mercury throughout the day. So for some people, that's enough to make the difference from being symptomatic with their orthostatic hypotension or not. We also know that exercise or passive movement and functional electrical stimulation with biking or rowing has been shown to improve orthostatic hypotension over time. Most patients with spinal cord injury will gradually adjust to their orthostatic hypotension, but they're relying on baroreceptors rather than changes in cardiac output to adjust for the drop in blood pressure. Next slide. There are two drugs that are commonly used for orthostatic hypotension. I just wanted to point out a few issues. Florinef used to sort of be the standard treatment that we would use to stimulate the release of salts and increase the blood volume. But this has really sort of fallen out of vogue, but it can be useful in patients who have SIADH. And we are predominantly using midodrine. Its value is it increases vascular tone, but it does elevate supine blood pressure. So if you're starting patients on midodrine, you want to start with a low dose and then check to make sure that they're not getting hypertensive at night when they might be asleep and not aware. And in patients who have a renal impairment or a bradyarrhythmia, normally we have to be very careful and start with very low doses of midodrine before we can get a sort of optimal therapy. Next slide, please. And let's skip this one, go to the next one, Suban, thank you. So we've talked a little bit about cardiometabolic disease risk, and anyone who's a family doctor or regulated healthcare professional will know we've talked a little bit about the increased risk of dyslipidemia related to neurogenic obesity after spinal cord injury, the propensity for patients to have central abdominal obesity, inflammatory stress, and to develop type 2 diabetes. And the third one, hypertension, that we see increased arterial stiffness and the development of hypertension in a growing proportion of the spinal cord injury population. These graphs of the relative proportion of patients that had normal lipids, blood glucose, or blood pressure comes from a cross-sectional study done by a student in my lab. The reason why I put this slide up is we spent a bit of time talking about dyslipidemia. I'm not talking as much about type 2 diabetes or hypertension, because the management of that is similar to what it would be, diabetes and hypertension is what it would be in the general population. But the management of dyslipidemia after spinal cord injury is unique and different from the general population. Next slide. So most family docs and people on the line are used to calculating a patient's Framingham risk score and then deciding whether a statin therapy is appropriate or not. And I do think you can use this flow diagram around the management of dyslipidemia, looking at who has a low, intermediate, or high risk using a Framingham risk score, because many patients with spinal cord injury would meet the Framingham risk thresholds. However, you may need to look at the spinal cord specific CMD risk factors, and then based on whether a person has 1, 3, or 5 risk factors, you can also use this diagram. But this can be used to make a decision about whether statin therapy is indicated or not. Next slide. And of course, with the introduction of statins, there are risks for patients developing myalgia and myositis. And it is very important for patients with spinal cord injury that we monitor their CKs and make sure that they're not having elevations in their creatinine kinase levels, and also that we monitor their thyroid function with the introduction of a statin. So I don't know how many people are routinely checking thyroid and CK with the introduction of a statin, but that's a little bit more important in the spinal cord injury population, particularly groups that often have myalgias associated with neuropathic pain at or above the level of their injury, and at or below the level of their injury, and myalgias above. So this is an important sort of check-in on comorbid conditions and making sure that the patient's not having muscle-related symptoms associated with the statin. But the statins really are the best for reducing all-cause mortality in those with cardiometabolic disease risk with or without diabetes. Next slide. When we think about pharmacotherapy for dyslipidemia, these is the sort of spectrum of treatments. Coenzyme Q10 is, of course, for increased inflammatory stress, that high C-reactive protein that is not associated with an infection. But let's talk a little bit about statins, fenofibrate, and niaspan. Rosuvastatin, we know, decreases the risk of cardiovascular outcomes such as heart attack or stroke and reduces all-cause mortality, as we just discussed. For most patients, I will usually start spinal cord injury patients on a lower dose of 5 to 10 milligrams if they just have subtle lipid abnormalities or an abnormal HDL to total cholesterol ratio at the beginning. But we do need to monitor them for that elevated CK, hypothyroidism, and an abnormal hemoglobin A1C. Next slide. But then the dosing, usually you can work them up to the standard 10 to 20 milligrams that most family doctors would be very familiar with in their practice. Fenofibrates are really great in the SCI patients to address dyslipidemia, and they have been shown to decrease the risk of cardiovascular outcomes in the general healthy population over age 18. And they're used to treat high cholesterol and high triglyceride levels. The two things you need to remember in terms of risk for SCI patients: if a patient has had a history of pancreatitis or a severe renal dysfunction, we are not going to use a fenofibrate. But I personally like the fenofibrates because they're easier to incorporate into a patient's routine, and it does help them often with their bowel routine as well. When they're on a fenofibrate, you do need to do that quarterly check of their liver enzymes, ALT, AST, GGT, when they start. And then once they're on longitudinal therapy, you probably check annually. Next slide. Niaspan, Dr. Nash has done a randomized controlled trial showing that it does improve the abnormalities in total cholesterol to HDL ratio. And this is also a really great drug. Niaspan works very well for patients who have autonomic dysfunction and the perception of being cold all the time, because niacin induces flushing. It can help people feel warmer. So it's a great choice for a patient with the abnormal HDL to total cholesterol ratios and who also has autonomic dysfunction and feels cold all the time. They actually seem to like niaspan. It makes them feel a little bit more comfortable and is also effective in altering their lipid profile. And as I mentioned earlier, you can use coenzyme Q10 starting at 100 milligrams, with that going up to 300 milligrams per day to lower inflammatory stress and try to get that CRP below the cardiac threshold of 6 for most labs in Ontario. Next slide. And of course, there's EasyTrol, which can be used alone or with statins to treat high cholesterol, LDL, triglyceride, and low HDLs in those who have hypercholesterolemia. And it can be used in concert with fenofibrate, and starting at a dose of 10 milligrams. So, similar to the able-bodied guideline, it's the same armamentarium of drugs. You just have to give a little bit more consideration to the patient's comorbidities that might influence your choice. And depending on the severity of the lipid or abnormality, whether you would start with a fenofibrate or a niaspan, or move to a statin and add EasyTrol, depending on the complexity of the patient's presentation. Next slide. So at this point, I'm just going to hand over to Suban, who's going to share some great information and results from a pilot project that we did in concert with Spinal Cord Injury Ontario. And I wanted to give a little shout out to Navi and Sheila Casemore from Spinal Cord Injury Ontario, who collaborated with us on the work that Suban's going to present. And thanks everyone, and Suban, over to you.
Thank you, Dr. Craven. Hi, everyone. So in addition to the drug therapies that Dr. Craven has mentioned, exercise has been one of the leading interventions in cardiometabolic disease treatment. It does improve arterial structure and function, glucose homeostasis, and lipid profiles, in addition to overall quality of life and fitness. And so far, most rehab settings, healthcare settings, they've been focused on neurorecovery. Of course, that is a priority after an injury, but there hasn't been enough work on exercise for cardiometabolic disease risk. So that's what we're leading towards, is trying to focus more and more on cardiometabolic disease in addition to neurorecovery. So the general guidelines, the PVA guidelines, the World Health Organization, you may have seen this already. It's 150 minutes per week, or they can be broken down into 30 to 60-minute sessions over 3 to 5 days, or 10-minute sessions 3 times a week. It's also, they realize that it should be based on ability. So even though that's the focus, of course, each individual's ability differs, and that's why they work with the exercise professional to focus on what they can and cannot do, and then start low and work their way up. Of course, the main thing is to avoid inactivity. So any amount of exercise is better than none. But an important thing about these guidelines is that when they published these guidelines, it was done mainly on the general healthy population and other populations with disabilities. But they didn't focus on spinal cord injury patients, and they didn't do enough research on them. And so there was more updated research guidelines that were published that focused more on the spinal cord population, and similar to the adverse events that could happen that I mentioned above, like orthostatic hypertension, or because they're using mostly upper body limbs, they can be overuse injuries or arrhythmias. So because of that, they tailored it more towards the spinal cord population. So these are the guidelines that they focused on. So they realized that this population can still get a lot of benefits, or cardiometabolic benefits, without reaching the 150-minute threshold. So if an individual has never exercised before, or they haven't exercised for a long time, they should aim towards more of a 20-minute session twice a week at a moderate to vigorous intensity, and then strength training, of course, for 10 reps at 3 sets twice a week. So this is more focused on cardiovascular fitness, cardiorespiratory fitness, but to aim towards more of the CMD benefits, they should work their way towards 30 minutes 3 times a week. So of course, again, it depends on the individual's capabilities. So they might not even be able to do 20 minutes at the start. So you can start them off a little bit lower dosage, and then eventually try to get them to 20 minutes twice a week, and then work their way up again to 30 minutes 3 times a week in a structured program. There's also more emerging evidence on HIIT training, and as many of you may be aware, there's a lot of evidence on HIIT training be beneficial or more beneficial in the general healthy population, and also in those with stroke and cardiac complications without disabilities. There's limited evidence on the spinal cord injury population as well, but there should be more and more precautions because of the arrhythmias that we mentioned earlier, temperature dysregulation. So there should be more focus on rest periods for pressure released, so that we reduce skin breakdown, and also the orthostatic hypotension as well. So warm up and cool down, of course, is always needed during the above guidelines. So before they get to a moderate intensity, they should at least warm up for 10 minutes at the start with stretching and light exercises, and then at the end also cool down, so a little bit lower intensity with similar motion, but so they can reduce their blood pressure and cool down that way. And then in healthy eating is another intervention that can be used in conjunction with exercise and drug therapy. Of course, persons with SCI typically require 20 to 25% fewer calories. But of course, again, it depends on the individual. And the more focus should be on the Mediterranean or DASH diet, and that's what the research has shown to be promoting heart health, because they focus on low sodium, high fiber, fruits and vegetables, low saturated fat. So this is just a diagram, as many of you have probably seen, what a Mediterranean diet will look like. And our colleagues at the Rumsey Cardiac Rehab Center at Toronto Rehab, they created a website for their patients called Cardiac College. And so I provided a link here. So it's an excellent resource for people living with cardiac complications and CMD in terms of healthy eating. There is exercise components there, but that's more tailored towards people without disabilities. However, it's still an excellent resource to use and direct patients towards the healthy eating sections there. So now we come back to what we've been doing at our rehab settings. So Dr. Craven and also Matthias West, who's in this meeting as well, they formed a working group to focus on certain domains that can focus on CMD risk. And as Dr. Craven mentioned earlier, they want to focus on items that are different from the general population. So those are the lipid profiles and exercise. So we included the barcode here, the QR code here. So if you want to take a look at that paper, the initial paper they published in 2019. And then they had a driver diagram here that looked at all the areas of focus at that time. And then they narrowed it down to lipid profiles and exercise intervention as the ones that they can focus on in the immediate future, and it won't take much time to implement, average around 6 minutes to collect that information at these rehab settings to drive future improvements in care. And then how we do it here in joint venture with Spinal Cord Injury Ontario, we used AI platforms to automatically extract data. So makes them more efficient. We can create report cards for patients and their healthcare providers to show the results of the data we collected and any suggestions we can provide. And all it takes is a quick survey on paper or iPad, and we can feed it through the system to extract the data. So instead of someone trying to manually enter each one and analyze it and report it, this can do it automatically. And then at the Linder's spinal cord injury rehab center setting, I collected the data for the intermediary outcome, which is the inpatient data while they were inpatient at the hospital. So this, I just took out a couple of the questions that we took from that data survey. So one was, has anyone in your healthcare team taught you about the need for long-term aerobic exercise? And has anyone shown you how to perform that exercise? And then also we looked at the lipid profile. So one of the questions was, did you receive a lipid profile assessment before you left rehab? So the results were actually really shocking, and it shows that we need there's a lot of room for improvement. So as you can see at the very left side, only 14% of the interviewees were taught about any aerobic exercise or the importance of aerobic exercise. And out of that 14%, so that was about N was equal to 116. So out of that 116, 14% were taught. And out of that 14%, only 69% of them were actually shown how to do it. So this really shows that we need to improve how we do exercise promotion at our rehab settings. Also on the right side, we have the lipid profile assessed. So the recall is what the question was, if they remember having a lipid profile assessed at the hospital, and only 15% said they had gotten it done. But then if you compare to the actual amount of people that got it done from when we accessed their blood work, only 30% have actually got it done. So this just shows two things. One, so 15% didn't recall them getting it done. And most of the time when I speak to these patients, they say that they have a lot of blood work getting done regularly, but they're not being told what it is or what's happening and what the results are. But even only 30% have actually got it done in the first place. So even there's a lot of room for improvement there. And then the final outcome indicator, these are the people living in the community that myself and the Spinal Cord Injury Ontario staff members have collected. And so this is usually what people are 18 months post-discharge. So we just ask them, are they doing any moderate or vigorous intensity aerobic exercise to maintain their heart health? And then also, again, the lipid profile, did they receive a lipid profile since their discharge from rehab? And so the results here shows that only 48% are doing any type of exercise. So if it's 1 day or 2 days, only 48% have done that. And then what's more astonishing is only 24% are actually meeting the guidelines for cardiometabolic disease. And then lipid profile assessment recall, again, 52%. So about half of them have got their blood work done. But the issue on the right side was that we couldn't access all the blood works for all the patients. So we weren't sure, for half of them, we weren't sure if they even got it done or not. So we couldn't really compare their actual recall to what they actually got done. So then during the interviews of data collection, these are the type of questions these are the type of steps that we would take to get an understanding of what they're doing and provide feedback if appropriate. So of course, if they're meeting the guidelines and they're getting the blood work done annually, then we don't really need to give them much feedback. We let them keep doing what they're doing and whatnot. But if they're not exercising or meeting the guidelines, we kind of get reasons for why they're not doing it and understand their exercise capacity and capability. Of course, that's more important to know these things to cater a little bit of the feedback towards them. And then, of course, since they're not doing it, we explain the importance based on what we mentioned above on why exercise is important to them and for heart health. And then we provide some options of exercise, or whether it's fitness centers in the community that they can go to, or stuff that they can do in their house or around their home in their neighborhood. We provide a bunch of options that they're interested in. Of course, if they're not interested in exercising at all or don't want to have any behavior change, then there's not much we can do there at this time, but if they are showing that they are a little bit interested and they want to learn more, then we provide some motivation interviewing to get them motivated to exercise more. And we have a guidance and some toolkits that we can use to create an action plan with them and provide to them, so they can also take it to their other exercise professionals and create a plan going forward. And then we also send them those toolkits afterwards. After our interview, we send them to them so they have it on file. And then we got back here to Dr. Craven.
Thanks, Suban. So we have room to do better. And just wanted people to just hammer home the dyslipidemia management, just a little bit more, use some of the common drugs, but a little bit more thought about some of the comorbid conditions that might influence your choice of drug and what monitoring is required for safety. But the treatment of diabetes and hypertension, which are very common in the chronic SCI population, is the same as the general population. So most family doctors should feel very empowered to begin to assess cardiometabolic risk and include it in their annual follow-up. Because of neurogenic obesity, patients with spinal cord injury are at higher risk for developing cardiometabolic disease years before their age-matched peers. Next slide. So we've tried to highlight for you today cardiometabolic risk after spinal cord injury. You can look at a 35-year-old male who's had a spinal cord injury for 20 years. They do need a cardiometabolic workup, but they wouldn't in the general population. So we want you to really think about, are you missing somebody's cardiometabolic risk? We've shared some intervention targets around lipids and exercise. We think these are near-term changes that are tough to make, but that family physicians and primary care providers could do to change a patient's future. We've shared some data from our QI project in partnership with SCIO, really highlighting how primary care providers can help us modify CMD risk with very simple interventions, a lipid assessment, and some simple exercise counseling. And there are some unique comorbid conditions that can complicate the CMD risk assessment or management. And if you run into those are appropriate reasons for a referral to physiatry or concurrent management with a cardiologist. So hopefully that provides you with a little bit more clarity and understanding of the next steps. Wanted to give a shout out to some of the members of our team who provided input to this project, including Masai Miatani and members of the consortium team. And if you want to learn more about us, you can go on our Craven Lab website. We do have a cardiometabolic section that has some tips and tools that people can access. So thanks. We're open to answer questions. If people have them, you can in the chat or raise your hand and Mout will be happy to try to answer you.
Thanks so much, Cathy and Suban. Yeah, we'll open it up to anybody if they want to either raise their hand or just come up with their question. Maybe I'll start. Cathy, I just want to get your thoughts on, you brought up the AD medications and that. So I just didn't know if there was any changes in sort of some of the abortive medications for acute episodes of AD. I know in the past, like there was always a lot of talk about using nitro paste and everything, but that's, I don't think, always been easy to get in Ontario or Canada.
Yeah, so the nitro paste, so people are recommending nitro paste, nitro spray, nitro patch for the person that's, knows what the precipitant is and you want to gradually bring down their blood pressure. The patches and pills are nice because you can take them off when the person's blood pressure normalizes before they bottom out. But certainly nitro spray would be good in an emergency. And then we still do have Adalat for those that can use it responsibly and manage it.
Yeah, perfect. So basically anything that's kind of fast acting, but of course you have to have the right patient and monitor for orthostatic hypotension, all that after, right?
Yeah, the big risk to them is that they get rebound symptoms, and then they become hypotensive, and then we're trying to raise their blood pressure. And Yeah, but basically those are still the mainstays right now. For the patients who, have had sustained high blood pressure and require admission to hospital, then we would insert an IV and we can give them hydralazine in a monitored setting to reduce their blood pressure. If we don't know like etiology, I've seen patients they're in the midst of passing a stone and they've got very severe AD that is prolonged for several hours. That's the type of person that would need to be admitted and maybe have hydralazine in a monitored setting where they've got an IV and we can raise their blood pressure with fluids or levofed if they go too low. So I don't know if that helps, Jamie, but in the new AD guidelines, one of the things that I think family physicians or primary care providers would be interested in is that there are now some recommendations for pre-intervention prophylaxis for some people that we didn't have previously. So if you have a chance to look in the guideline, there's a couple of good recommendations, particularly for those who have known autonomic dysfunction for things like urodynamics or colonoscopy or those kinds of things, that there is some pre-procedure recommendations that we didn't have in the prior guidelines.
Oh, that's great. Yeah, I'll have to check it out.
So there's a lower threshold for initiating treatment than we had in the past, and some new recommendations around peri-procedural management of AD that are sort of the biggest and newest contributions, but the armamentarium of drugs really hasn't changed very much.
Great.
Yeah.
I'll see if there's any other questions from anybody else.
It's Joe. Yeah, thanks, Suban and Cathy, for a really great presentation. And I think you're right to say, things like lipid monitoring, metabolic assessment generally are, what we do pretty regularly. And it's good to highlight. We sometimes get very distracted from, with SCI or other comorbidities that, because we're dealing with whatever's at hand. But, there's a good point about starting earlier because, we usually start more for the general population depending on their other risks like family history and whatnot, at either 40 or 50. And you mentioned maybe 30, I guess, might be a good time to start screening. And just also on that, like our current guidelines are the lipids, if they're okay, every 3 to 5 years as opposed to yearly. But do you have a suggestion with regards to when to start screening and at what frequency you would say?
So this is Craven's opinion, not guideline derived. So for those people with motor complete injury, I would say 10 years after injury onset is when those complications start to coalesce. So, if you had your injury onset at 16, you would start screening at 26. If you happen to have your spinal cord injury onset at age 55 or 56, which I think is the mean in the province right now, we should be starting it right away. We are seeing that around 10 years post-injury is when male paraplegics will start to develop hypertension and have the dyslipidemia or early propensity for type 2 diabetes. So I would say 10 years after spinal cord injury onset for those under the age of 40. And for those over the age of 40, I think you already have some current guidelines when you can start. So, and it would sort of also depend on the person. I mean, somebody who is premorbidly obese and, had, borderline prediabetes, that person you're going to want to move to annually right away. The person who had, normal BMI, was very active and remains active after their spinal cord injury, you could maybe do it every 3 years.
Okay, thank you. That's very helpful. I am sorry I have to go to another thing, but I really enjoyed the talk. So thank you very much for coming.
Thanks, Joe.
I see Vanessa's got a question there.
Yeah, thank you, Cathy, for the lecture. It was very informative. And I was just thinking, as the data you showed about the importance of exercise and really that being an opportunity to address the cardiometabolic risk. Do you see the opportunity for activity monitors? You know, we have Apple Watches and that would those provide reliable data as a source for individuals with spinal cord injury to track activity, and then for that data to maybe that's already going into your AI kind of platform around that data. So just wondering if those are validated and would be a source to help understand activity.
Yeah, it's a great question, Vanessa. I don't think we know the answer. Yeah, I don't know if there's other people on the line who are doing work looking at activity monitors, but you know, it's something to really think about. We know that like the heart rate and blood pressure estimates are pretty good with the Apple Watch, even in spinal cord injury. But I don't know that anybody's done it to say, can you actually monitor activity? There was a project that Mark Nash was working on with Kathleen. I don't know the outcome of it, but I can certainly reach out and ask them. And so, and there are some projects going on at Toronto Rehab with in concert with Apple, but I don't know that it's been shown in spinal cord injury that I'm aware of. But if there's anybody who knows better or different on the line, I'm happy to be corrected.
Great, thank you.
Okay, any more final questions? Again, I'd like to, you know, sincerely thank Cathy and Suban for their time and their expertise today. Just a great presentation.